Hello everyone, my name is Maria Belén Palma, I'm from Argentina. I'm an intern at Hospital Fernández in Buenos Aires. On behalf of Natalia Labarta and Florencia del Bustio, I'm going to present a case related to monoclonal gammopathies and the role of the laboratory in its diagnosis. We are biochemists currently working at the Laboratory of Clinical Chemistry in the area devoted to the study of proteins. We are very grateful for the opportunity we were given to share this case with all of you and to make the role of the laboratory more visible, which has always been silenced and is essential for the patient health care. In this presentation, I'm going to develop the following topics. I will go through the case introduction, the diagnosis and the role of the laboratory, the treatment and evolution, and finally, some conclusions. To begin with, I will describe the subject of our case. A 73-year-old male patient who is a smoker with hypertension, preferred to have undergone a radical prostatectomy in 2016, consulted for lumbar pain of 6 months of evolution associated with lower limb weakness and weight loss of approximately 9 kilograms in the last 4 days. The patient is evaluated by the trauma service who requested a spinal tomography where osteolytic images are observed in L1 and L3. The neurosurgery service was consulted suggesting clinical and oncological studies for diagnosis purposes. The patient was hospitalized for follow-up in our hospital. The lab tests showed that the patient had anemia, hypercalcemia, and hyperproteinemia. The rest of the results were normal, as you can see in the slide. We performed an agarose gel electrophoretic proteinogram where a monoclonal component with beta-globulin mobility was observed. The position of the component doesn't allow estimation of the concentration by measuring the densitometric peak. In order to identify the monoclonal component, an immunofixation test was performed. As shown in the image, a monoclonal component of IgA lambda identity was observed. A second band was also observed to have a homogeneous reaction against lambda antiserum, which didn't react with the anti-heavy chains antiserum tested, alpha, gamma, and mu. Given the result observed, it was suggested to send a new serum sample from the measurement of beta-2 microglobulin and quantification of immunoglobulins together with a 24-hour urine collection sample to search for Benz-Jones protein. When the 24-hour urine sample was sent, immunofixation was performed to detect the presence of free monoclonal light chains in the urine, Benz-Jones protein. As shown in the image, the patient has a free monoclonal light chain of the lambda isotype in the urine. In conclusion, he has Benz-Jones proteinuria. For this study, serum and urine sample from the patient were used. The electrophoretic separation of protein from both samples on the same gel, combined with a new immunofixation, made it possible to compare the mobility of the bands observed in both samples. As we can see in the second picture, the patient has a monoclonal component of IgA lambda identity in serum. We can also observe the presence of Benz-Jones protein in serum, which has the same mobility as the homogeneous band of the same reaction seen in the urine sample. This second band doesn't show a reaction against the anti-heavy chain in serum tested. This indicates Benz-Jones reflex. It's necessary to clarify that our laboratory doesn't test epsilon or delta antiserum. As expected, the patient presented an increase in beta-2 microglobulin and an increase in total IgA, with decrease in the uninvolved immunoglobulins. Given the result obtained in the laboratory studies, a bone marrow puncture aspiration was performed, where it was observed plasma cell infiltration of 60% of total cellularity with a decrease in the myeloid series. Considering that the patient presented plasmatic cell infiltration greater than 10%, anemia, hypercalcemia, and osteolytic lesions evident by images, according to criteria proposed by the Argentine Society of Hematology, which is term based on the criteria of myeloma working group. The diagnosis of multiple myeloma was made. For the evaluation of severity, a dosage of free light chains in serum is requested. The results show considerable increase in lambda line chains and a pathological ratio for involved and uninvolved chains. The ratio around 100, together with the degree of spinal cord infiltration greater than or equal to 60%, and the number of bone lesions detected, more than one on focal lesions, are considered biomarkers of malignancy. Therefore, we can say that our patient has a bad prognosis. A few days later, the patient started treatment with bortezomib, cyclophosphamide, and pamirodate. 1 month later, an electrophoretic proteinogram and control immunofixation were performed. This made it possible to identify a very good partial response in the patient since his monoclonal component wasn't observed in the electrophoretic proteinogram, but it was in the serum immunofixation. These graphs show how hypercalcemia, hyperproteinemia, and anemia improved. This demonstrates the important role of the laboratory in patient follow-up. As a conclusion, in the case that we have presented, it is shown that the contribution of the laboratory was essential for the diagnosis of the pathology, which allowed a rapid treatment. The intervention of our service continues to be important for patient follow-up and evaluation of the response to the indicated therapeutic measures. The rapid diagnosis, together with the interdisciplinary approach, collaborate in the prompt appropriate treatment. Thanks for your attention. Muchas gracias.